I want you to imagine a scenario. You are 75 years old. You feel absolutely fine. You're active, you're gardening, maybe you're still driving. You go to your doctor for a routine checkup, and your blood pressure reads 145/85. The doctor frowns. They say, "We need to get that down. The golden rule is 130/80. So they prescribe a stronger pill, or maybe they double your dosage. Indeed, the normal blood pressure is under 120/80. For people treated for hypertension, many guidelines aim for below 130/80 if tolerated. But older adults sometimes need individualized targets. 2 weeks later, on paper, your numbers look perfect. You are sitting at 118/75. But you don't feel perfect. You feel tired. You feel a little brain fog. You feel a lack of motivation. And then, one evening, the phone rings. You stand up quickly from your chair to answer it, and the room spins. Your vision goes dark. You have to grab the table to stop yourself from hitting the floor. This isn't just a hypothetical scenario. This is the reality for thousands of seniors right now. I was reading through our community comments recently, and I saw a terrifying story from a viewer named Sea Hunters 1. He was 73 years old. His doctor forced his pressure down to 120/80 with medication. One evening, he stood up to answer a phone call, blacked out completely, hit his knees on the hard floor, and smashed his chin on a toolbox. He ended up in the emergency room. And the kicker? Once he stopped the medication and managed it naturally, he was fine. Why is this happening? Because for decades, we've been told that lower is always better. But new research published in JAMA Internal Medicine and the Age and Aging Journal is screaming a different warning. In some older or frail individuals, very low pressures, especially with symptoms or orthostatic drops, may be associated with worse outcomes, and intensive treatment can increase hypotension or syncope risk. This is why targets should be individualized. I'm Dr. Oleksii Kalmykov. Today, we are going to look at the undeniable truth about your blood pressure numbers. We are going to calculate your specific sweet spot, because a healthy 65-year-old and a frail 85-year-old should not have the same target. And I'm going to teach you the sit-to-stand test to save you from a dangerous fall. First, we have to respect the biology of aging. We need to have an honest conversation about your arteries. When you're 25 years old, your arteries are like fresh rubber garden hoses. They're elastic, they expand and contract easily with every heartbeat. But as we age, specifically past 60 and 70, our arteries naturally stiffen. They become more like rigid metal pipes. This happens to almost everyone. It's a part of the aging process called arteriosclerosis. Now, think about gravity. Your heart is a pump. It has to pump blood up against gravity to get oxygen to your brain. If you have rigid arteries that don't expand well, your heart actually needs a slightly higher pressure to push that blood through those stiff pipes and get it all the way up to your head. If we aggressively drug your pressure down to 120 systolic, the number we use for a 30-year-old, we might be creating a situation where there simply isn't enough hydraulic pressure to perfuse the brain. This is why we see comments like the one from Peter Trevathan, who said, "I'm 73, I was 145/85 and felt good. Doc was unhappy. Now I'm 120/60. I get dizzy and feel tired." Peter, if you're watching this, your body was telling you something important. That tiredness may be your brain's signal that it needs more oxygen. The medical community is finally catching up to this. The SPRINT trial, which was a massive study that pushed for lower blood pressure, initially suggested everyone should be lower, but subsequent analysis has shown that for frail elderly patients, these aggressive targets can be dangerous. This brings us to the most dangerous trap for seniors: orthostatic hypotension. That's a fancy medical term for your blood pressure crashes when you stand up. Here's the scary statistic you need to know. Research from the Journal of the American Geriatrics Society shows that a drop of just 20 points when you stand up is a massive independent risk factor for falls and fractures. And falls, as we know, are the #1 cause of injury-related death in seniors. Here's the problem with how modern medicine handles this. You go to the doctor, you sit in the waiting room for 20 minutes, you walk into the exam room and sit down again. The nurse comes in, puts the cuff on your arm, and takes your pressure while you're sitting comfortably. It reads 125/75. The doctor says, "Great job, keep taking the meds." But you don't live your life sitting in a chair. You get up to go to the bathroom at night. You get up to answer the door. You get up to cook. If your pressure is 120 when you sit, but your arteries are stiff and your medication is blocking your body's natural ability to compensate, your pressure might drop to 90 or 80 the moment you stand up. That's when the lights go out. That's when the hip fracture happens. So how do you know if you're at risk? I want to give you the sit-to-stand protocol right now. This is something you can do at home with your own monitor. Step 1. Take your blood pressure after sitting quietly for 5 minutes. Write it down. Step 2. Stand up. Wait 1 minute while standing. Keep the cuff on. Take the reading again while standing. Step 3. Wait another 2 minutes, so you've been standing for a total of 3 minutes. Take it a third time. Safety note. Stop the test if severe symptoms occur. Do it near a stable surface. Consider supervision if prior falls. If your top number, the systolic, drops by 20 points or more, or your bottom number drops by 10 points or more, you have orthostatic hypotension. If you're taking medication and you have this drop, you are at high risk. You need to tell your doctor immediately, "My pressure is good sitting, but it crashes when I stand." Now let's talk about the numbers. If 120/80 isn't the golden rule for everyone, what is? We look at the U-curve data from recent studies involving frail older adults. Imagine the letter U. On the left side, where blood pressure is very low, mortality is high. On the right side, where blood pressure is very high, mortality is also high. But in the middle, that's where survival is longest. For a robust senior, someone between 65 and 75 who is active, walking, and has no major frailty, we usually aim for a systolic between 130 and 139. This protects the kidneys and heart without starving the brain. However, for seniors over 75 or those who are more frail, the research suggests a target of 130 to 150 systolic might actually be safer. While for better results, targets should be individualized, frailty, symptoms, standing blood pressure drops, and diastolic blood pressure matter. I saw a comment from Ron Loft, who is 81 years old. He said his pressure is 160/55, but he goes to the gym daily and walks over 3 miles. Now, Ron is an outlier, and 160 is generally higher than we want, but he proves a point. Treating the number is different than treating the patient. If we forced Ron down to 120, he might lose the energy to walk those 3 miles, and walking 3 miles a day is likely doing more for his longevity than the medication would. However, I have to be responsible here. We have to look at the danger zone. If your top number is consistently over 160 or 170, that is too high. That puts too much mechanical strain on the vessel walls, increasing stroke risk. Conversely, if your top number is consistently under 110 or 120 and you are on medication and you are over 75, we worry about your brain. This leads me to the connection that terrifies most of us more than a heart attack: dementia and Alzheimer's. There is a fascinating study in the journal Hypertension that highlighted the link between hypotension, low blood pressure, and cognitive decline. Think of your brain like a garden on top of a hill. If the water pressure in the hose is too weak, the water doesn't reach the flowers at the top. The flowers wilt. If you over-medicate a 75-year-old to the point where their average pressure is 110, we are seeing reduced perfusion to the brain. This is called cerebral hypoperfusion. Over years, this lack of blood flow can accelerate cognitive decline. I saw a comment from a viewer named TW1486 who said, "Mine has been too low, dizzy, lightheaded, confused." That confusion is a warning sign. It is not just getting old, it could be getting underperfused. If you or a loved one has been diagnosed with mild cognitive impairment and they are on aggressive blood pressure medication, it is worth asking the doctor if the medication could be contributing to the mental fog. We also need to look at the diastolic number, the bottom number. This is the pressure in your arteries when your heart is resting. The heart muscle itself gets its blood supply during this resting phase. If your diastolic drops too low, say below 60, your heart might not be getting enough blood. This as a clinical caution sign warranting medication review, not a universal rule. This is particularly relevant for those of you with a wide pulse pressure, which is the difference between the top and bottom numbers. I saw many comments from people like Steve Montgomery, age 73, with 181/99, or Richard Thompson, 72, with 164/105. These numbers are definitely in the range where we need to take action. We aren't saying ignore high blood pressure. We are saying the target needs to be realistic and safe. So, how do we fix this? We don't want you to stop your meds cold turkey. That is dangerous and can cause a stroke due to rebound hypertension. But we want you to have an empowered, data-driven conversation with your doctor. I've put together a 7-step safety protocol for you to determine your safe, individualized target. Ditch the one-off reading. Do not rely on one stressful reading at the doctor's office. White coat syndrome is real, and it causes doctors to overprescribe. Measure at home, relaxed, in the morning before coffee. The sit-to-stand test. Do this tomorrow morning. If you drop 20 points standing, you are at risk and your medication needs review. Hydration. This is so simple but so often overlooked. Many seniors are chronically dehydrated. As we age, our thirst mechanism fades. Dehydration lowers your blood volume, making orthostatic hypotension much worse. Before adding a pill, try adding 2 glasses of water to your daily routine. Hydration helps some people, but if you have heart failure or kidney disease, confirm safe fluid targets with your clinician. Review the cocktail. Are you on 3 or 4 different blood pressure meds? The more drugs you mix, the higher the risk of side effects and falls. Ask your doctor, can we simplify this? Am I overtreated? Listen to your body. If you feel dizzy, lightheaded, or lethargic, log it in a notebook alongside your blood pressure reading. That data, 110/60, felt dizzy, is more important to a good doctor than the number alone. Individualize your target. Ask your doctor specifically, given my age, is 135 or 140 a safer target for me than 120? Force the conversation about the guidelines for the elderly. The safe landing. If you and your doctor decide to reduce meds, do it slowly. Tapering is key. You are the expert on how you feel. Medical guidelines are averages based on thousands of people, but you are an individual. You are not a statistic. If you found this helpful, please share this video with a friend or a family member who is struggling with dizziness or fatigue. It might just be their blood pressure meds. I've linked the JAMA and SPRINT trial studies in the description below, so you can print them out and take them to your next appointment. Stay safe, listen to your body, and I'll see you in the next video. Would you like me to create a summary table of the recommended blood pressure targets by age group to make this even easier to discuss with a doctor?